Hi, everyone, and welcome to Becker's 10th annual CEO and CFO Roundtable virtual event. I'm Erica Carbajal with Becker's Hospital Review, and thank you for joining us for this featured session where we'll discuss how primary care is ripe for disruption. Major tech and retail pharmacies like Amazon and Walgreens have taken note and made several investments and acquisitions in this space. But what will the disruption mean for health systems? During this session, experts will discuss the acceleration, challenges, and opportunities in primary care, and the rising role of value-based care models that health system executives need to consider in the coming years. So before we get started, I'd like to introduce each of our speakers today. So we have Andy Mueller, CEO of MaineHealth. We have Steve Sell, CEO of Agilon Health. And finally, Eric Klein, a partner at Sheppard Mullin. So thank you all so much for being here today. We'd love it if you could also take a moment and just tell us a bit more about your roles and organizations before we get started. So Steve, can I start with you?
Sure, Erica, thrilled to be here. Steve Sell, CEO of Agilon Health. We're a company whose vision is to transform healthcare at the community level by partnering with primary care organizations, and excited to share that with you today.
Eric?
Hi, Erica. I'm Eric Klein from Sheppard Mullin. I lead the healthcare team nationally at Sheppard and work across the entire primary care, but also value-based and risk-based space, leading a team of over 250 attorneys on the healthcare team. Thank you.
Andy?
Hey, yeah, I'm Andy. I'm a family physician and the CEO of MaineHealth, representing 22,000 care team members in what is really the largest integrated care delivery network north of Boston, servicing southern Maine and eastern New Hampshire.
Great. Thank you all again for your time and for being here today. So we'll get started just kind of with an overview of primary care. So how would you characterize primary care today in terms of industry and patient value? Eric, can you speak to this?
Sure, happy to. So if you look at primary care today, we're seeing a huge spotlight being shown on that particular sector. Why? Because much of the country right now is starting its shift or accelerating its shift towards value-based and risk-based payment models. That is really critical when it comes to primary care. A couple different reasons for that. The first is that you've got attribution. You know, the primary care doctor is the one who holds the financial responsibility and is the quarterback, if you will, for both value-based care and for risk-based payment models. So that's really important to be able to access and to work with the primary care physician. Secondly, in models that are successful, where we see substantial improvements in quality and outcome, and where we also see significant reductions in total cost of care, it's driven by the primary care physician. Because one of the things that we have today is we've got a very fragmented healthcare system. We all know it. You know, there's lots of money in the healthcare system. There's lots of great people and great systems in the healthcare system, but many of them do not work well together. And that's not their fault necessarily. It's just how our system has grown up, and we just don't have the plumbing, if you will, coming together to make things happen in the way that they should. Sort of like, when you need to go shopping, you can wind up going to a department store, but if you're in the area where you're shopping for tools, you're certainly not going to be able to find your clothing. And it's the same thing, unfortunately, these days at many clinics, many hospitals, and many physicians' offices, where you go in for one thing, but then you only get that one perspective. So when we think about what's going on with the trend away from traditional fee-for-service, we're seeing a huge acceleration. Kaiser Family Foundation recently had their graph published in the New York Times, where it showed that in the next year or two, they expect that more than half of all Medicare beneficiaries will be enrolled in Medicare Advantage. That is significant, because when we look at that and you look at the trend towards managed Medicaid, 1 out of every 2 babies on average across the country right now are being paid for by Medicaid. So, we really do see quite a large amount of folks that are in these types of value-based or risk-based systems. That being said, very few of the primary care systems out there connect the dots effectively. And it can make a huge difference because, the best systems, the best approaches to this wind up with a coordinated care system with interventions, with application of data at the point of care, where you can really make the difference. And we've seen a lot of concern in the Medicare Advantage program about Medicare risk adjustment and scores and whether or not that's causing overpayments or not. The real key here is to get the analysis, to get the information, and to provide it. And we've seen some of the most effective companies not focused on Medicare risk adjustment, HCC RAF scores, but focused on quality outcome and total cost of care reduction. And if you look at the national average, for example, in Medicare Advantage for bed days per thousand for seniors, it's running about 1,700 bed days per year. That's a lot of money when you consider that bed days per thousand can be 10,000, 12,000, 14,000, depending upon your market. The best performing groups where they go ahead and they are under a risk-based system oftentimes can reduce that by more than 1,000 bed days per thousand seniors. And we see that getting down from 1,700 to somewhere in the 600 to 800 or 900 range. That's a huge difference. It's trillions of dollars of savings. And also, it really improves the care because nobody needs to go get care that's not required, not necessary. And we're seeing too much of that. So the models today are really interesting because what they're doing is they're trying to address new approaches, one of which is to connect the dots between hospital systems, health systems, which are, frankly, where the consumer has the most trust. They trust their health system and they can get all the resources there. But we need to connect the dots better there to be able to make sure that what they get is what they need. And to do that, many health systems need to step into a new arena, technology, information, analytics, capital that they may not have or may not be willing to spend on their own. We're also seeing a lot of new entrants as well. You mentioned Amazon with their potential acquisition of One Medical. You mentioned Walgreens, which purchased a majority interest in Village MD last year. We see a full range, and it goes all the way from convenient care, as I call it, where you've got the CVS approach, where folks show up and they have a nurse practitioner or other advanced practice professional who can do certain things, but it doesn't provide full-on primary care. To the well care, if you will, the folks like at One Medical, which does a great job providing care, but it's to many folks who are younger and don't necessarily have chronic conditions, to folks that are really focused on, the seniors that have got multiple chronic conditions. So long story short, we're going to see a lot of innovation, a lot of disruption coming up, and it's got the potential to do some really great things. That's part of why I'm really excited about what Steve and Andy have been able to put together recently, which is just a really interesting and, to my mind, transformative model.
Well, Eric, thanks so much for that overview of primary care and, kind of explaining why there's such a focus on the importance of primary care providers today and the value that they're going to bring as the shift to value-based care accelerates. Now, next year, you touched on it a bit, Eric, but where does the model need to be improved? Steve and Andy, can you weigh in here?
Sure, maybe I'll start, Andy. So I think, as Eric said, it's really primary care's time. It's such an exciting time to be in primary care. People recognize the value that primary care physicians can bring as that overall care quarterback to really organize, to really integrate. But primary care physicians today don't have a business model that allows them to spend the most time with those most complex patients, as Eric talked about. They don't necessarily have the information they need or the resources that they need to make that happen. So I think what we're really trying to do in partnership with great organizations like Andy's at MaineHealth is really partner with primary care organizations who've been in their communities for decades, organizations that are incredibly well respected, and move existing doctors, existing patients, and existing health plans from the challenges of the fee-for-service world that we just talked about, and move them into a coordinated full risk world in which that primary care doctor and the care team is responsible for the total care and cost for that senior patient. The aging population in this country, the Medicare population over 65 with complex conditions, presents tremendous strains on a primary care physician. And really only with this move in terms of a payment model are we able to create a partnership that allows us to invest, that provide care team resources, folks like social workers, care managers, pharmacists that are in the office with that primary care physician, that allows for more time with those most complex patients. And really it's a team-based overall care model that yields exceptional outcomes in terms of both experience for the patient, but in terms of reduced costs and better experience overall. So that's really at the heart of what we're trying to do. And we found that every type of primary care organization in the country really needs a new primary care model, really needs the ability to make those investments, to really leverage all of the expertise and knowledge they've got locally. And we're so excited to be working with Andy in Maine. He's a tremendous leader, and we're in our implementation process right now. We're going live on January 1st of 2023, but this will be our first health system. And Andy, why don't you share some of the thoughts about what you saw and what can be improved in Maine?
Yeah, for sure, Steve. And, and I think a lot of similar thoughts. We recognize that the business model needs to change for healthcare broadly, but it certainly needs to change for primary care. And in a lot of ways, Medicare Advantage gives us a vehicle to think about how we look at that business differently. The reality is, Steve, if you beamed a patient from the 1970s, into a modern primary care office and gave them the same experience, they're going to recognize most elements of it because it really hasn't changed materially all that much. And so as you speak about things like team-based care, that's going to be really important to us, because to really effectively manage a broader population of patients, we're not going to be able to do it one patient at a time, one after another in the office like we've done in the past. And part of that is going to be having to make needed investments in primary care. I remember being a medical student and some of our faculty members telling us there may not be a need for primary care in the future. And I laugh now thinking about the tremendous access challenges and demand we have for primary care services. And so I think patients see the value in it. So in a partnership like we've created between our organizations, we've got an opportunity to be intentional about how we change the business model, how we create team-based care, and how we make intentional investments and reinvestments in primary care to create a more sustainable, accessible, equitable model for how we want to deliver care into the future.
Sure, thank you both. And it's also great to hear how agilon is expanding now, working with MaineHealth as the first health system. It's an exciting time there. Steve, I saw you took yourself off mute. I'm not sure if you wanted to.
Well, I was just going to add that, when Andy talks about this investment in local primary care, what we've been able to do is we're live in 17 markets with partners who've been in their communities for decades. We are reinvesting about $10 million a month into local primary care. And for the first time, you're seeing primary care stabilize and grow within these communities. People are joining out of residency programs. People are coming back into primary care. And so I think there's an energy when you're able to work with a partner like MaineHealth, who is so well respected within their community, and physicians talk with one another. And so that excitement, that true partnership that we govern together and operate together and allows for investment back in the community is really yielding some exciting results. And if you've been in healthcare for a long time, you could be a little cynical. I'm so optimistic and excited about the positive momentum that we're generating in a true partnership.
I want to go back to disruptors. I know we mentioned them a few times already, but how do these new entrants coming into the industry upend the status quo, or what will the impact be on physicians, systems, and patients?
I think one of the things that we'll have to think about is they certainly see primary care as an opportunity. I think all of us see it as sort of, in many cases, the front door to the healthcare system and the natural place for patients to want to connect. And so I think, there's a risk that if we're not careful and continue to try to create transactional relationships as traditional healthcare providers with our patients, we're going to miss huge opportunities, which is why changing that business model is going to be so important to us. I also think that disruptors are going to have the ability to not necessarily be bound by some of the dogma that has really sort of restricted our thinking, I think, sometimes in traditional healthcare around the use of telehealth, the use of really your flexibility around your schedule to create access, and thinking about how to work not only with patients directly, but those who are paying for care directly, including employers. So I think if we're not careful in changing that paradigm, we run the risk of being on the sidelines looking back in.
And I think what I would say is whether you're talking about Amazon or CVS or Walgreens, I think it's significant that they've really identified primary care as an area that's ripe for disruption, right? The experience isn't all that great today for the patient or for the physician. The challenges that they're facing around it. The access model is challenged, and it's a little bit dated. Andy talked about going back to the 1970s and not a lot of change within it. There's been a underinvestment within technology, and the information that's available to the patient and the physician are all areas that are ripe for improvement. I think what we've seen is we believe that patient-physician relationship really sits at the heart of it. And we really want to enhance and strengthen that with those care team resources around the primary care physician. I think it reinforces that the primary care doctor could be the catalyst for this transformation of health overall. And, as we talked about our vision with Andy and what they were trying to do at MaineHealth, this idea around improving the overall health of the community, transforming that primary care doctor can kind of uniquely do that. So it's a very holistic view. I think that the investment in primary care from some of the new entrants is going to make us better. It's going to force us to be better around that. But I also think we have the greatest thing you have in healthcare, which is a trusted relationship between the doctor and the patient that we're starting with, that you can build around, that should give us lasting results in terms of that. But I think it's an exciting time, and it's one in which we all have to kind of step up our game and be better.
Great points about those disruptors' entry into the market, really accelerating health systems prioritization of primary care. And Eric, did you have anything else to add here?
Well, one of the things I wanted to add here was when we think about primary care today, part of it is, as was said before, it's been under-resourced. And in large part, that's because, the way that primary care physicians have been acting is in order to be able to meet the financial requirements of their own practice, of the organization that they're working with, they have to see a lot of patients. And that is a treadmill to nowhere. It's a gerbil wheel, if you will. And what we've seen is when you work smarter with better data, with a care team wrapped around you, with the right type of IT, et cetera, and with a better process overall, it allows you to spend more time with your patients, and that makes a huge difference. What we found over time, working with many of the leading organizations that do global risk around the country, we do more global risk deals than any other law firm in the country, so we see quite a bit. What we found is that it's that attention, it's that relationship with the physician and the patient that ultimately drives the care and reduces the duplication, because you don't need to have the additional specialist visits that may or may not be required. You don't need to have two sets of imaging because you've got one imaging set being done by one specialist, another being done by another specialist, et cetera. So it really does improve the patient's life, but it also dramatically drops the cost. The other thing that I think is really interesting that I think has to be thought about in the context of new disruptors coming in is, where do the economics align? So if you're looking at this and all you're doing is you're just coming in as a single shot primary care solution, well, we've had lots of single shot approaches before, and some of them have been very helpful, but it's very hard to succeed if you're not partnering with other folks. And if you're doing it by inorganic growth, if you only grow by buying other practices or by buying things, that's very expensive. It's a lot of money and it's a lot of turnaround to get there. Also, when we think about that cost, what it does is it means that you're constantly integrating. You're constantly trying to improve. So you're always sort of, starting from a couple of feet underground. Let's contrast that with a partnering model where you're working with top-level folks, whether it's health systems, whether it's primary care groups, et cetera, in the community, they're already doing a good job. So we can start a little bit higher up the food chain if you want and improve things, and it gives you more room there. Finally, the last thing I mention is what I really am excited about from the health system perspective here is that this type of approach really solves one of the pervasive issues we've seen across the country for health systems, which is many, many health systems are losing money on their Medicare patients. Why? Because they don't have the systems in place right now to effectively manage them. They're making money on their commercial patients, they're losing money on their Medicare and on their Medicaid patients. When you move into a global risk or full risk model, as Steve was saying, all of a sudden there's dollars available and there's infrastructure that you can put in place that can transform that. So we've seen in multiple situations where there's an effective adoption of a global risk arrangement in Medicare, whether it's through an ACO REACH, whether it's through a Medicare Advantage play, et cetera. We've seen health systems be able to go in the black and also at the same time improve the quality of care for their patients. That's a big win-win.
Absolutely. Now, we've talked about primary care, the landscape of that today, the importance of transforming and shifting into value-based care. But Andy, can you touch on specifically how health system leaders can navigate this new route successfully?
Yeah, I think there are a couple of key things that we'll have to think about. So one is not losing sight of what we're trying to accomplish. And so for us at MaineHealth, our vision is working together so our communities are the healthiest in America. And of course, that nicely aligns with the work that Agilon is trying to do, and really, I think, behind the intent of Medicare Advantage. And so making sure all of that's aligned is important. The second thing I think is reflecting upon what Eric and Steve have both said, which I think the most important thing in helping us achieve that vision is trusting relationships between patients and physicians. That ultimately is really what is going to drive behavior and ultimately improve outcomes. And so ensuring that our care delivery teams, including the physicians, the APPs, the nurses, the medical assistants, the front office, really have the ability to build that trust with patients is going to be critical. I think to Eric's point just now that we'd be remiss as an integrated healthcare delivery system if we weren't thinking beyond just Medicare Advantage, that we need to learn from our experience with Medicare Advantage, but then translate that to other patients, other payer classes, to think about how we transform our bigger business, not just primary care, and thinking about that for the future. The data and analytics that Agilon brings to us, for example, is invaluable. We have to be able to have insight and a spotlight on actually our actions, how they impact the patients, and how that helps us get better over time. And so that was one of the things that really attracted us to this partnership. And then ultimately, we've got to really continue to think about that experience of our physicians. It's going to be a super competitive marketplace for primary care physicians. There aren't enough of them to go around, and the same is going to be true for APPs. So we need to make sure that we're doing everything we can to reduce the burden on them from being the data entry clerks in the healthcare system, giving them a great experience in terms of the tools they need, the care team that they need to deliver that experience, making sure they've got a voice at the table and helping us design this for the future. And I think while I don't think any of us can truly tell you every single step that we'll need to do to be successful, we're sort of charting this path as we go. I think those are some key fundamental things that'll be required for us to ultimately get to the other side of the chain.
And Eric, if I can add, just since we've announced the partnership with Andy and the team at MaineHealth, the level of interest from other health systems has really taken off, and Andy's been great about talking to some of those leaders as they think about this. But some of the common areas that they seem to all be thinking about are some of the things that Andy and Eric both talked about. One is, how do I think about this aging senior population moving into Medicare and what that means for me overall? So sort of a Medicare strategy for the system overall. The second is the incredible value that they see in their primary care physicians, whether they're employed or the independent physicians that they're working with in the community. And so a primary care strategy, how do I start to think about that? How can that help me overall as I make this move into value? Medicare is the logical place to start with this and move, given the costs and the challenges and the demographics. But it really is for them a holistic view. And there's a lot of conversations that's going on with their board, with their medical groups and others about how we think about that. So it's a pretty unique time. And it's conversations that are going on across the country.
Sure. Thank you both for kind of providing that overview in terms of a framework of starting with Medicare Advantage, but Andy, as you said, not being remiss and ensuring we're thinking ultimately in the future beyond that. Steve, can I go back to you just from an agilon perspective? How does your value model accelerate the process?
Yeah. Well, we really value and pride ourselves on going to communities and being first, working with a partner there at scale, and moving the entire community to risk for the first time, starting with this senior population. We will work with existing doctors, existing patients, existing health plans, and move them from that fee-for-service world into value. The pace at which we do it is very unique. We have a very structured 12-month implementation. We're in that right now with Andy and the MaineHealth team. But the idea is you are really moving into this team-based sport. You are surrounding them with resources in terms of a care team within that office that gives them the ability to spend more time with their most complex patients and make sure as that patient is leaving the office that you have the greatest likelihood of success. So they might be meeting with a social worker or a care manager. The ability to invest and have resources outside of that office at those critical juncture points, whether it's in the ER, whether it's rounding on the hospital floor, perhaps within skilled nursing facilities, all that are part of that primary care physician's care team and really taking that holistic view. And so what we try to do, Erica, to make this move is give that primary care physician the information they need on their patient profile to stratify who those most complex patients are, give them information on physicians and facilities within the community. They understand that well, but we give them data, as Andy talked about, from a cost perspective, from a quality perspective, in terms of, say, cardiology, and what the total spend and outcomes could be depending upon the cardiologist that you're referring to around that. So they've got information on those complex patients. They've got information on the physicians that they work with. And we really are able to allow them sometimes to see fewer patients within the day, but focus more on those most complex patients. So I think where we do it is unique. We're going to these communities with these partners, doing it for the first time. The scale at which we're doing it is unique. Andy and his group, as an example, might have 25, 30, 35% market share, an equivalent amount of sort of the primary care capacity within those communities, which is so important as you're trying to change overall healthcare delivery. And then the pace and speed at which we're doing it in terms of a 12-month implementation period is very different. You might hear typically about a 3 or 4 or 5 year glide path with payers. And then the last thing I would say is we're able to organize all of the health plans within the community, the folks that Andy has been working with historically as an example in Maine, and make that move with them into this full risk relationship. So the payment model changes, but we also get an agreement on there's going to be one approach to quality. There's going to be one approach around access, regardless of the card that senior patient is bringing in when they see the primary care physician, the front office staff, the physician, the care team, all understand that there's going to be a real common approach to how they handle that. And that really helps dramatically. You know, variation within healthcare is one of the biggest challenges that we've got. And the ability to treat all senior patients from the same approach in terms of process can really drive to some of the improvements we talked about from a cost and quality and that experience, the experience for the physician, the experience for the care team, what that senior patient sees and feels as they're going through all of that. So that's what we're really focused on. We're in business together with the MaineHealth Medical Group and Andy. We operate at 50-50. We govern at 50-50. We each bring kind of unique things to the party to make that happen. But we're able to, in short order, within 12 months, make a leap into a new world that can be really transformational for our partner and for the communities they serve.
Yeah, and Erica, just to add to that, Steve talked a lot about the what of what they do, but just to give a little more background from our perspective on the why and the how. We always begin any partnership conversation with a conversation about our vision of working together so our communities are the healthiest in America, and asking a potential partner, how will you help us achieve that? And that answer was very clear for the agilon team in recognizing they really want to make an impact in the patients that they're involved in caring for. And we saw that very clearly. I think one of the things for any health systems considering something like this is you can't consider this as a transaction. We don't. It goes back to our vision statement of working together so our communities are the healthiest in America. And we know that together word's important. Our vision is so aspirational. We know we can't do that alone. We're going to have to partner with others. And so when we view partnerships, we view them like a marriage, and that's how we view this with agilon. This is not a transaction. It really is about working together to transform how we deliver care. And so one of the things that I think agilon also brings to the table is, even though they've had a really proven track record, which gave us a great deal of confidence, and even though they've got great demonstrated results, they were willing to listen to us because they knew we'd be different as their first integrated health system delivery partner. And it's that bidirectional communication, that willingness to really partner like in a marriage, that I think is ultimately going to help us become successful together. And I think that's one of the things that agilon really certainly brings to the table that's very important.
And just following on that for one more second, just building on what Steve said, and then also what Andy said as well. Steve mentioned the word stratification, and risk stratification is really critical when it comes to treating patients these days. If you look at Medicare Advantage, a number of the studies I've seen, and I've seen this very much in practice with some of the largest global risk Medicare Advantage organizations across the country, about 4% of Medicare Advantage members account for about 40% of the costs, 4% and 40%. So if you can risk stratify, you can put the resources where you need to put them, and then that leaves potentially, if you're successful in better managing the health and helping maintain stability or improvement for that 4%, that leaves you with a lot of other dollars that you can invest into the community and that you can build together. But it's not just about stratification. As Andy said, it's also bidirectional. You've got to be able to take that information and translate it into action. And that's where the partnership model can be very effective.
Yeah. And Erica, just one last thing, a lot of what agilon brings to the table would be, some of it maybe we could do ourselves, but at what cost and over what length of time? And so we really saw a skilled partner that has demonstrated their ability to do this, that to Steve's point, will accelerate us rapidly in a less than a 12-month period, to be able to really get engaged this way, to begin changing how we deliver primary care experience. And I think one of the conversations with our own physicians that was enlightening was just sort of, asking the question, what are we missing if we don't do this sooner? And one of the answers was potentially better outcomes for our patients. And how long are we willing to wait on that?
Eric, I'll give you an example. I mean, what Andy and Eric are talking about is we've created a business model that rewards our partners for the first time for really investing in more resources and spending more time with the most complex patients. And so this year, as an example, we're seeing a 12+% increase in terms of the touch points with those most complex patients, spending more time with those folks. Some of these patients are being touched daily by a care manager because you're talking about such a complexity that occurs around that. And there's just tremendous stories out there about senior patients who are able to spend more time with loved ones, patients that are able to take trips for the first time in decades and go see grandkids in another state because of the intensity of care that they're getting from that broad care team, not just the primary care doctor, that's allowing them to make small changes in their overall health and really manage progressive diseases. And that's kind of what we're here to do. It translates into dramatic improvements in terms of cost, but the quality and the experience is really what gets an awful lot of people out of bed in the morning. And it's why I'm as excited and optimistic as I've been in a long time.
Sharing, the benefits that the partnership can bring in terms of risk stratification, as well as, Andy, back to what you mentioned of ensuring physicians are in a place where they can build those trusting relationships with their patients. Before we wrap up here, I want to get to the primary care shortage, which we all know is a nationwide problem. So can you each speak to how health systems can bolster their efforts to attract and retain primary care providers?
Yeah, it's going to be competitive out there. And in some ways, particularly as a not-for-profit healthcare system, our hands are a little bit tied compared to what some of the for-profit organizations can do in terms of compensation and other things. So we really have to think about it holistically in terms of really aligning the work of the primary care physicians with really what motivates them around keeping their patients healthy and understanding that they really are going to have the ability to make an impact on that and have a successful living doing that too, and feel economically incentivized to do the things that align with that. It's really around creating that real team environment where they feel supported holistically around the delivery of care, where they've got access to data in front of them that gives them, that doesn't overwhelm them, but gives them the tools and the ability to improve how they're delivering care and feel good about making those improvements. And then ultimately, as I mentioned before, we've got to take away some of the barriers, some of the crazy makers that really impact our primary care, including the amount of time they have to spend in the electronic health record. And that's something we're trying to do as an organization to figure out how we can divorce them from that task more and more. And then, quite honestly, and Steve and I have had some of these conversations. I think educating our own is important. Education is a third of our mission at MaineHealth, and we've got a jointly ventured medical school in conjunction with Tufts University. We've got 15 residencies and 12 fellowships, including primary care. And so we think that growing our own primary care physicians, our own primary care APPs, is going to be an important part of our strategy moving forward. And the beautiful thing about doing that is we can educate them in this new model. We can educate them in how the future is going to look and really give them the opportunity to take a hammer and nails and start building it with us and for our patients for the future. And I think it can be a really exciting time to become a primary care physician or APP.
Yeah, I would just say the headline is we need more primary care doctors in the country, period. Everything that we're talking about starts with that precious asset, which is the primary care doctor. And it's pretty cool that so many people recognize that. I think the first thing you need to do is you need to stop what's causing primary care doctors to leave adult primary care medicine in the first place. Burnout, the fee-for-service system is rampant. Eric talked about it. We have a shortage today. That shortage is only projected to grow. But really, as you talk about what we're doing in this new primary care model, the ability to practice medicine the way you were trained and to spend more time with those most complex patients and have resources around you that allows to manage, social conditions and understand pharma from a perspective of sort of drug-to-drug interactions and make sure that there's adherence for medications, major issue for seniors as an example. To have someone on your care team that's doing that for you is really, it's a tremendous benefit to that primary care doctor and allows them to be more fulfilled and more successful in what they're trying to do. So, one of the areas that we're really proud of is what we've done with our female physician leadership group across our network. Staggering statistic that not only do our adult primary care physicians leaving practice, but female physicians are leaving at a much faster rate. Within 6 years of graduating from medical school, it's something like 50 to 60% of adult primary care female physicians have either left altogether or have dramatically reduced their panel size and the amount of time that they're spending on it. And so what we found is female doctors really flourish in this team-based world. They have tremendous relationships with their patients. They communicate well, they coordinate well. And so it's something that I'm really proud of. We've got a group of energized women physicians across our network, and there's an energy to it. And we're seeing for the first time physicians who left adult primary care actually coming back into it, in addition to new physicians joining. So you have to slow the exit. You also need to draw people back in and add in new, but all of that's part of this. And then we need to use extenders in a more aggressive way than maybe we have historically in terms of nurse practitioners and PAs. So I think there's just tremendous opportunity here to really put those primary care physicians where they belong, to be at sort of the top of the pyramid and coordinating that overall care.
Well, great. Thank you all so much for your time today, Eric, Andy, and Steve. I also want to thank Agilon Health for sponsoring today's featured session, and to our attendees, thank you so much for being part of the 10th annual CEO CFO Roundtable. Do check out the other sessions that we have going on during the event, and let us know if you have any questions, feedback, or any other comments. Thanks again for joining us, and we look forward to having you at future events.
Thanks, Erica. Andy, Eric, thanks a lot.
Yeah, you bet. Thank you.
Thanks.